Cholera is an acute, rapidly progressive, waterborne diarrheal disease caused by the bacterium Vibrio cholerae, primarily serogroups O1 and O139. It is characterized by painless, profuse watery diarrhea, often described as rice water stool. Without prompt treatment, cholera can lead to severe dehydration, electrolyte imbalance, and death within hours. 1. Causative agent. The disease is caused by Vibrio cholerae, a gram-negative, comma-shaped bacterium. Pathogenicity depends on the production of cholera toxin, CT. Cholera toxin increases cyclic AMP levels in the intestinal epithelial cells, causing massive secretion of water and salts into the intestinal lumen. 2. Transmission. Cholera spreads primarily through the fecal-oral route, including drinking contaminated water, eating contaminated food, especially raw or undercooked seafood, poor sanitation and hygiene, contamination during food preparation by infected individuals. Outbreaks are common where there is crowding, refugee camps, urban slums. Clean water access is limited. Sanitation systems are weak. 3. Incubation period. Few hours to 5 days, usually 2 to 3 days. 4. Clinical features. Cholera symptoms range from mild to severe. Key signs include A. Diarrhea. Sudden onset of profuse, watery diarrhea. Rice water appearance, clear stool with mucus flecks. No fever, no abdominal pain. B. Vomiting. Frequent, non-bilious vomiting. C. Dehydration. Signs include sunken eyes, dry mouth and skin, poor skin turgor, rapid, weak pulse, thirst and restlessness, loss of consciousness, late sign. D. Complications. Hypovolemic shock, acute kidney injury, metabolic acidosis, electrolyte imbalance, especially low potassium, death if untreated. 5. Diagnosis. Diagnosis is based on clinical signs. Severe watery diarrhea during an outbreak is enough for clinical diagnosis. Laboratory confirmation. Stool culture is the gold standard. Rapid diagnostic tests, RDTs, are useful in outbreak settings. Dark field microscopy can show motile vibrios. 6. Treatment. Treatment must begin immediately. A. Rehydration. The cornerstone of treatment. ORS, oral rehydration solution, for most patients. For fluids, Ringer's lactate, for severe dehydration. Ongoing reassessment of hydration. B. Antibiotics. Used for moderate to severe cases. Doxycycline, single dose. Azithromycin. Ciprofloxacin, depending on resistance patterns. Antibiotics reduce duration of diarrhea, stool volume, bacterial shedding. C. Zinc supplementation. Especially beneficial for children. Reduces duration and severity of diarrhea. 7. Prevention and control. A. Water, sanitation, and hygiene, wash. Safe drinking water, boiled, chlorinated, or filtered. Proper disposal of feces. Hand washing with soap and clean water. Safe food preparation and storage. B. Vaccination. Oral cholera vaccines, OCV. Dukoral, Chantal, Uvacol. Effective for outbreak control. Travelers to endemic areas. High-risk populations. C. Community measures. Immediate reporting of cases. Isolation and treatment of patients. Disinfection of water sources. Public health education. 8. Epidemiology. Cholera affects 1.3 to 4 million people globally every year. Causes 21,000 to 143,000 deaths annually. Outbreaks occur in Africa, South Asia, and areas with humanitarian crises. 9. Pathophysiology, advanced explanation. Cholera toxin binds to GM1 ganglioside receptors on intestinal cells. Activates adenylate cyclase, increases CAMP. This opens chloride channels, massive chloride, sodium, and water secretion. Leads to rapid dehydration and electrolyte loss. 10. Public health impact. Cholera is a disease of inequality. Hits hardest in communities with poor infrastructure. Rapid urbanization and climate change, flooding, increase outbreaks. Effective prevention requires coordinated wash plus vaccination strategies.